Good afternoon and welcome back to this second session. Now I have with me, sitting on my left, Dr. A. Satvik, Surgical Specialist, Dr. Ram Manohar Lohia Hospital, New Delhi. He would be talking about recent advances in the field of surgery. To my immediate right is Dr. Naresh Gupta, and to his right is Dr. Parag Kalra, working in the board as the Assistant Medical Executive. Before I start, I would again like to remind the viewers to contact us anytime for any queries at the toll-free number of 1800112345. May I please request Dr. Satvik to begin with the session, sir?
Yeah, many thanks, Shalini. My name is Dr. Satvik. I wish you all a very good afternoon. And after this very exhaustive lecture on recent advances in medicine by the illustrious Professor Gupta from Maulana Azad, I will give you a brief overview about recent advances in surgery. If I could have my slides on the screen, please. Could I please have my slides on the screen? Yes, this is a quotation which is attributed to Bill Gates way back in 1981 when he reportedly said that 640 kilobytes of memory ought to be enough for anybody. Now that seems immensely stupid for anybody to say, because now one would be predisposed to reject a computer with a memory of 40 gigabytes. In fact, one would be looking for an external hard disk drive which has a memory of 40 gigabytes. So we must embrace technology on every bend, otherwise we'll be left far behind. Now, recent advances in any discipline would encompass one of the following: paradigm shifts, new techniques, new technology, and new trials. Now, consider these to be overlapping circles, because you might have new techniques with paradigm shifts, you might have new technology with paradigm shifts, and all of these would actually be directed by evidence obtained from new trials. Now, a paradigm shift in a surgical discipline would mean that a set of assumptions or a set of propositions have been completely waylaid by a new set. Therefore, we've now learned to start looking at an illness or a malady from a completely new perspective. I'll give you an example of a paradigm shift in surgery. When we applied Pascal's law for abdominal wall hernias, we realized that if one were to place a mesh in the preperitoneal space, that is behind the defect, as opposed to in front of the defect, one would get a more secure repair, because an increase in the intra-abdominal pressure would actually firmly hold the mesh against the defect, as opposed to a condition where the mesh were placed in front of the defect. So the gold standard now is a preperitoneal repair of a hernia, where a mesh is placed in the space of Bogros, in the preperitoneal space, and this was done in the open technique by Nyhus and Condon, and has been subsequently adopted by Stopas, and then adapted to laparoscopic techniques such as totally extraperitoneal repair and transabdominal preperitoneal repair. Another paradigm shift would be the use of gene transfer for peripheral vascular disease, which I'll be talking about in the course of my lecture, because it is now becoming clearer that one can actually use alternative forms of therapy to recanalize a vessel, and sometimes to bypass a vessel with the help of collaterals. One needn't use a physical bypass graft. One may actually inject substances which have been produced in vitro from genetic engineering to recanalize a vessel or to produce collaterals. Similarly, in Berger's disease or thromboangiitis obliterans, one discovered that Elizarov, which is a technique used in orthopedics for distraction osteogenesis, led to collaterals. So after trying so many things in Berger's disease and failing miserably, Elizarov has opened up new avenues. Similar paradigm shifts are being noted in the management of hemorrhoids with the advent of stapled anopexy, which I'll be talking about more elaborately in the course of my lecture, and also sentinel node biopsy, where surgeons have discovered that in the case of cancer breast, the axilla can be staged, or an attempt can be made to stage the axilla by evaluating the first nodal station of lymphatic drainage. New techniques have revolutionized our surgical disciplines and re-energized them. For example, endopilotomy. I'm not giving the example of endopilotomy as a new advance. This is just to illustrate how new techniques would bring about newer advances. Endopilotomy is a procedure where a hole is made in the kidney, and by an antegrade technique, you incise the stricture at the pelviureteric junction. This was a newer method which was adopted a few years back, and it showed a lot of promise against the older method where by open surgery the pelvis was dismembered, the strictural segment was removed, and the pelvis was refashioned. Similarly, transurethral resection of the prostate was a case study where newer technique was used to remove the prostatic adenoma from within rather than without. Laparoscopic adjustable gastric bands replaced the old kind of banding in bariatric surgery, which was the vertical banded stapled gastroplasty. These laparoscopic bands are adjustable, they're removable, they can be loosened or tightened, and therefore show a lot of promise in morbid obesity. And another topic which I'll be talking about extensively will be subintimal angioplasty, which is a new form of recanalization used in endovascular surgery. New technology has heralded many changes, for example, robotics, endovascular lasers, and radiofrequency ablations. So, to give a brief overview of the topics I will be talking about in the course of this lecture, first would be the role of genetics in surgery. Then we'll be talking about PET scanning and its applications in surgical oncology. We'll be talking about stapled anopexy, robotics and telesurgery, notes on natural orifice transluminal endoscopic surgery, radiofrequency ablation of tumors, and endovascular surgery. And finally, I'll be briefly mentioning live donor liver transplants. So let us begin by talking about genetics in surgery. I know most surgical candidates will find this topic very drab. We're not used to memorizing long labyrinthine genetic and molecular names, but a brief overview nevertheless. Various applications in genetics. First, screening of disease, especially cancers. Secondly, to understand and alter disease biology. Thirdly, to obtain prognostic information in cancers especially. And finally, gene therapy. These are ways in which genetics has altered the surgical disciplines. To begin with screening. Now, we're all familiar with the condition familial adenomatous polyposis. This is a condition where almost the entire large bowel is studded with polyps, and this is as a result of the mutation in the adenomatous polyposis coli gene. Most probands, most of the people who have this gene are likely to develop at least one colorectal cancer in their lifetime, and relatives within the affected pedigree can be subjected to a screening of the APC gene, and if this gene is found, then one can think of offering prophylactic surgery to relatives of FAP. The other application would be in breast and ovarian cancer. In hereditary breast and ovarian cancer, identification of BRCA1 and BRCA2 genes would mean almost a certain chance of getting cancer of the breast in the person's lifetime, and therefore immediate relatives can be offered the prospect of either aggressive surveillance or chemoprophylaxis, or even prophylactic bilateral subcutaneous mastectomies. Satellite mismatches in plasma DNA are also seen in certain cancers, like non-small cell lung cancer, and KRAS proto-oncogene mutations are seen in stool samples in patients who have colorectal adenomas as small as 1 centimeter. So this is a brief overview of how genetics can be used in screening to alter the course of various diseases and to pick up cases early. You can also use genetics to stage cancers. Earlier, we would talk about simple microscopy being used to identify metastatic deposits in lymph nodes, and then we moved on to something called as immunohistochemistry to identify metastases in lymph nodes. But now you have the presence of tumor mRNA in lymph nodes, even in immunohistochemically clear lymph nodes. So you have evidence of genetic micrometastases. The clinical applications of having genetic micrometastases are being debated. Its applications will be clear in the years to come, but this is clearly an area which is going to change management of cancers. Genetics have a grand role to play in prognostication. For example, we find that overexpression of genes which encode for CERB-B2 in cancer of the breast indicate early tumor relapse. MSI is a bad prognostic index in non-small cell lung cancer, but it's good in colorectal and gastric cancers. And the other example that I'd like to give is the loss of chromosome 17q, which indicates poor prognosis after Whipple's pancreaticoduodenectomy. A little something about gene therapy. Gene therapy is not really this. Gene therapy has two components. One is pharmacogenetics, and the other is actual therapy. Now, something about pharmacogenetics. There are inherited differences in every individual which alter this person's response to therapy. The classic example would be the CERB-B2 overexpression in the case of cancer of the breast. The person who has overexpression of this will show better response to doxorubicin. So these are candidates where doxorubicin may be given. Similarly, beta-tubulin mutations in non-small cell lung cancers, in these patients, poor response will be found to paclitaxel. So taxanes are to be avoided in these patients. Gene therapy has a great role to play in malignancies. The attempt here is to correct pathological cell processes at the gene expression level. Examples are, you may modulate chemotherapy. There's something called as gene-directed enzyme prodrug therapy, where with the help of a virus which has been genetically engineered, a part of the gene is actually introduced into the tumor cells. Now, this gene has been trained, so to say, to convert a prodrug which is given into a cytotoxic substance. So these cells, the tumor cells which have been selectively transfected by this gene, will convert the prodrug into a cytotoxic substance and be destroyed, and the normal cells will not be affected. So this is gene-directed enzyme prodrug therapy. Then you have something called as genetic immunotherapy, where in vitro genes will be encoding tumor-associated antigens, and these will be injected to produce antibodies. And finally, you have something called as corrective gene therapy, where you will induce mutations that will suppress neoplastic phenotypes. Some applications of genetics in vascular disease. It has been found that certain growth factors, predominantly the vascular endothelial growth factor, which is produced in vitro as a result of genetic engineering and then injected intra-arterially and intramuscularly, will lead to angiogenesis and therefore a kind of revascularization. Similarly, angiostatic agents are also used to ensure long-term bypass graft patency rates. The application of genetics in pancreatic disease. Cystic fibrosis is a disease which affects the pancreas and the lungs, and this is because of a gene mutation, CFTR. And in these patients, normal human CFTR genes can be introduced into the respiratory epithelium by a process I'm about to show in an illustration next. This is the illustration you can see on the left-hand side corner of your screen. This is a virus, an adenovirus, which contains the DNA that has to be injected into the host. and this has been manipulated as a result of genetic engineering. This will breach the respiratory epithelium, will enter the cell in a vesicle. The vesicle will lyse, and the vector or the virus will be released inside. This virus will introduce this gene into the nucleus of the cell and bring about changes in the cell that would correct the deficiency. This is how genetic engineering can change the management of cystic fibrosis. Now we move to other diagnostic areas and the clinical applications of PET scanning in surgical oncology. PET stands for positron emission tomography. There's an illustration. I apologize for the poor quality of the illustration, but you'll see that what happens is that radioactive isotopes, when they decay, they release a positron. Now this positron collides with an electron in its vicinity and produces two gamma rays. These gamma rays are picked up by gamma cameras as bright spots, and this is the basis for positron emission tomography. So essentially, to recapitulate, PET scanning is a metabolic imaging modality. So it does not detect anatomy, but it detects function. What is carried out is a short-lived radioactive tracer isotope which decays by emitting a positron is injected into the subject. Then you wait for a period, which is normally an hour, while the metabolically active molecule becomes concentrated in the tissue of interest. Then you scan this patient. In malignancies, fluorodeoxyglucose is commonly used, as glucose is commonly concentrated in malignant cells due to an increase in membrane glucose transporters and other enzymes. And then the gamma rays that are produced as a result of collision with the electrons are picked up by gamma cameras. Clinical applications of PET scanning in surgical oncology are immense, but many of them are not practical. They may be used for screening for primary cancer. For instance, you can just subject a patient to a PET scan to find out if he has cancer, but it's not practical, it's not cost effective, and it has high false negative rates in patients who have cancers less than 5 millimeters in diameter, and false positive expressions where some areas of inflammation might give false positive results. But it is of some value in detecting primary cancers like non-small cell lung cancer and pancreatic adenocarcinoma. It is very useful to distinguish small lung cancers from tubercular areas or other lesions, and also to distinguish between pancreatic adenocarcinoma and chronic pancreatitis, which also leads to masses in the pancreas. But I think its preliminary value is in staging primary cancer. Imagine putting a patient through a PET scanner and immediately it gives you areas which show cancers. This is of immense value. So the stage of the cancer will completely change, and therefore the management again will completely change. Needless surgeries can be avoided, and more aggression can be shown in selective areas. It has also immense value in detecting recurrent cancer, post-radiotherapy, where there is scar tissue and you're not certain on other modalities of imaging if the cancer has recurred. A PET scan will immediately tell you if there is any recurrence. And it has some applications also in evaluating subclinical response to treatment, especially when you're giving chemotherapy or radiotherapy, to find out if the tumor has completely melted away. This is an illustration, or a photograph rather, of the PET scanner. The body is passed through the ring you see in that photograph. The ring is actually a detector ring. It consists of small photomultiplier units which contain scintillator crystals, and these detect the gamma rays which are caused by the collision of the positron and the electron. This is a superimposed image of a CT scan and a PET scan. On the left hand side you can see that there's a small pulmonary nodule in the left hand lung apex, which is picked up on a CT scan. But on the PET scan, which is imposed on the CT scan, you can find out that he has deposits in the abdomen, perhaps para-aortic lymph nodes, and also deposits in the pelvis. So the stage of the disease is completely changed, and you will consider alternative forms of therapy in this patient. So this is truly splendid, revolutionary technology, especially in surgical oncology. I shall briefly talk about stapled anopexy, which is again teaching us to look at hemorrhoidal disease with a new perspective. Something about anatomy of hemorrhoids. You can see that hemorrhoids are caused by descent of the anal cushions. This is a new philosophy that we're all adopting in understanding hemorrhoidal disease. You can see that the anal cushions have descended, and this is recognized as the cause of interno-external hemorrhoids. Earlier it was believed, as in the Milligan-Morgan technique, that the surgical treatment for hemorrhoids was just to pluck these hemorrhoids out or excise them surgically. But now we believe that that is one way of doing it, but a more physiological way would be this, which is to fix the hemorrhoid back, or the anal cushion back in its physiological position. So the technique used is called stapled hemorrhoidectomy, also known as stapled anopexy, also known as circumferential mucosectomy. What is done is a transparent anoscope is introduced with a large white colored obturator, which you can see on the left hand side illustration on your screen. This anoscope is in place. The transparent anoscope is fixed to the anal verge with sutures. Then the main obturator is removed and a semi-obturator is introduced, as you can see in the right hand side photograph on your screen. So this is a half obturator which occupies half the space in the anoscope, but the other half is occupied by a needle holder with a needle, and this is used to take circumferential purse string suture about 5 to 6 centimeters proximal to the dentate line. This is all along the rectal mucosa, and the stitch only takes the mucosa and not the layers beneath the mucosa. Once the purse string has been taken, a circular stapler, which is the PPH stapler, is introduced through the purse string beyond. The purse string is tightened and is notches in the and then the stapler is approximated and fired. What it does is that it removes a band or a ribbon of mucosa circumferentially, and therefore repositions the anal cushions back in its anatomical and physiological position, as will be seen in the final diagram. You can see the staple line, which is well above the pedicle of the hemorrhoids, and the anal cushions and the hemorrhoids have been repositioned. So this is stapled anopexy. It's fixing the hemorrhoids back in its normal position. This procedure can be carried out as daycare surgery. Many people are doing it under local anesthesia with perianal blocks, but a vast majority